Thank you, David. And thank you to David and to Axel for inviting me to talk today on immunotherapy and GI cancers. I'm going to focus mostly on colorectal cancer because that's what I spend most of my time doing. And then I will briefly talk about some other tumors toward the end. These are my disclosures. So I like to start off any talk on immunotherapy by looking at the field as a whole, and for us to realize how far we've come in the last 8 years with the approval of many different immunotherapies, mostly checkpoint inhibitors for the treatments of cancers. And this is a table of all the different indications across 1, 2, 3, 4, 5 different checkpoint inhibitor drugs. There are other kinds of immune therapies, such as antivirals, but these are the checkpoint inhibitors that I'm talking about. So up until now, we have 18 different indications in 8 different tumors: melanoma, small cell and non-small cell lung cancer, kidney, Hodgkin's lymphoma, head and neck, bladder, and as of yesterday, we're adding Merkel cell cancer to this spectrum. So we've come a long way, but obviously there is one tumor and one class of tumors that is obviously missing, and the one that we hope to see there is microsatellite stable colon cancer, but we don't know yet when there will be an approved indication for this, but this is where our efforts are targeted, in addition to other GI tumors that will take their place alongside colon cancer. And in fact, if you look back on the history of how we've developed immunotherapy, right back in 2008, when we first described the concept that random mutations in cancer can lead to these so-called neoepitopes that can be the targets of immune responses, this was then modeled on the sequence of 12 different tumors, which were colon cancer and breast cancer. So the idea that an immune response can be generated against neoepitopes was based on colon cancer. We know that colon cancer has sufficient mutations in order to elicit an immune response. In fact, there are the same number of mutations as in head and neck cancer and gastric cancer, yet the response rates have been overwhelmingly disappointing so far, and there's lots of work to be done. But we need to remind ourselves that colorectal cancer is immunogenic. There are successes that are going to start to emerge, albeit with MSI-high tumors. There's efforts that will look at microsatellite stable. We know that there's an immune infiltrate within colon cancer. The degree of the immune infiltrate needs to be characterized, but there are associations with improved outcome. And up until now, many immunotherapy strategies have been studied in colorectal cancer, most of those in early phase clinical trials, very few objective responses with the exceptions of MSI-high tumors. The negative trials, what we know does not work in conventional colon cancer across multiple trials is single agent PD-1 or a PD-L1 by itself. There are at least 5 trials up here, as well as CTLA-4, which had 1 out of 47 patients respond. We don't know what the MSI-high status of that patient was. So lots of negative data. We know not to give a PD-1 blocker, at least Nivo, Pembro, or Tremi by itself. We do also know from the pivotal study of success in MSI-high tumors, which is well known to the group, that these are responsive to PD-1 blockers. This is the Keynote 018 trial that showed a 62% response rate to pembrolizumab in MSI-high tumors, and this concept was subsequently validated in the nivolumab study, Nivo plus ipilimumab, presented by Mark Overman, initially at ASCO last year, and then subsequently updated. And here, what you can see on the left side is the Swimmers plot, and then the waterfall plot below that on the left is nivolumab alone, with a response rate of now 31%, and on the right side, the combination of nivolumab plus ipilimumab, which looks like there may be a better response rate, but that it really needs to be better well characterized, more follow-up, and we'll await further data on that. But on the left side, what is reassuring here is that there's a subsequent validation of responses in MSI-high tumors with a disease control rate of 69%. So overall, if you look at this data compared to the pembrolizumab data, you can't compare them head-to-head. These are 2 small studies, but I think they are really comparable if you consider both response rates and disease control rates together. And in fact, the NCCN guidelines now reflect that, and there's an option to treat patients with MSI-high colon cancer with nivolumab or pembrolizumab after progression on the frontline chemotherapy. This was subsequently also shown for Atezolizumab, presented by Dr. Hochster, and this is slides that he shared with me from GI ASCO. This was a large phase 1 trial looking at combinations of Atezolizumab plus Bev plus chemotherapy, and what he had reported were the 10 patients with MSI-high colon cancer. And you can see similar benefit with these prolonged durable responses, even if or durable responses or durable stable disease put together as clinical benefit with a PR of 4 out of 10, 40%, and stable disease in 50%. This has led to current studies. There's the Keynote 164 study and the Keynote 177 study. The 164 is a larger study to further validate the efficacy of pembrolizumab in refractory patients. This is fully accrued, and we're waiting for the data to see really what the response rate is in this larger population. And then there's the key question, which is going to be addressed in the Keynote 177, which is being accrued, and that's PD-1 blockade versus standard therapy in MSI-high colon cancer. And this is an ongoing study that is enrolling and will eventually tell us what the utility is of PD-1 blockade in the upfront setting versus standard chemotherapy, such as FOLFOX or FOLFIRI. If we take this back away from MSI-high, where we know there's efficacy, and we take this to microsatellite stable, up until now, there's been lots of discussions about the challenges of converting these uninflamed tumors into an inflamed phenotype. We think of an inflamed phenotype because that's where we've seen responses, lung cancer, melanoma. These are tumors that have immune infiltrates, unlike the majority of colon cancers. And we talk about challenges, but really what we should be talking about are these emerging strategies that have really come to the forefront for the future of immunotherapy. And we have many emerging strategies that we can look back on. And this is our entire toolbox to make immunotherapy work for colon cancer from this year going forward. As a segue into an emerging strategy, I'm going to divert and I'm going to talk about CAR T cells. This is a strategy that's been around for a long time. It has yet to find a specific place in the treatment of GI cancers, in particular colon cancer, but perhaps we can learn some lessons from CAR T cell technology, right? We know that this works in hematological cancers. We're still defining how this works in solid tumors. But as a reminder, a chimeric antigen receptor T cell has either a T cell receptor that's been engineered to recognize a specific target that's either presented via an MHC or a surface protein, but it's a T cell that's been engineered to look for something. And what was done at this trial at the NCI was to create a CAR T cell that recognizes CEA, because there will be more CEA on the tumor than on normal tissues, albeit expressed in both locations. And here it was given to 3 patients with metastatic colon cancer, and there was benefit, albeit with toxicity. On the left there, you see a transient drop in CEA, which is reassuring that there's something happening with the CAR T cell in this tumor type. And on the right, you can see the tumor regressions, with the top panel showing a liver metastasis, and then a liver metastasis below that, and then looks like a retroperitoneal node at the bottom. So in these 3 patients, there was evidence that CAR T cells can work against CEA. However, the caveat is that these patients developed adverse events, primarily with the GI toxicity in the colon. So this was not considered a tolerable regimen to go forward, but as a proof of principle, there may be something there. The next interesting trial that emerged from the NCI is if we don't take T cells and engineer them to look for a target, but you take the T cells out of the tumor, take those tumor-infiltrating lymphocytes and see what they're already recognizing, can you then make them stronger and put them back in the patient to go back and recognize what they were trained to do in the first place? And yes, you can, and you can target KRAS. And this question comes up from many patients because there was a lot of publicity around this clinical trial. So this was an adoptive T cell therapy using ex vivo expanded TILs. And we know that this works with profound responses and durable responses in melanoma, and it's probably mediated against these neoepitopes, not against melanoma differentiations, but against the neoepitope. So the trial that they did here was to take infiltrating lymphocytes from patients with metastatic cancer, including patients with colon cancer, then see what those lymphocytes could recognize, expand them, and put them back into patients. And in one patient, this patient 40905, had these CD8 cells, right, the warriors of the immune system, that recognized the conventional KRAS G12D mutation within a specific type of an MHC. The patient had a myeloablative therapy to remove all their other T cells. These expanded T cells were put back in, and they had regression of 7 lung lesions at the time of their first follow-up visit. So this is a profound effect, and again, a proof of principle that T cells can be expanded. There's a lot of challenges technically to doing this, but the idea can work. The patient had a 9-month partial response, but then had an escape lesion that was subsequently resected and disease-free for 4 months thereafter. If you look at the 4 bottom panels there, you can see going left to right, the lung lesions getting smaller in panel 1, similarly in panel 2. In panel 3, you can see an initial response, but then there was an escape lesion. That's the one that was resected. panel 4 was another lung lesion that regressed. So there is a role for creating T cells that can recognize tumor-specific antigens in colon cancer, but this is one patient out of many, many patients we've tried immune therapy on in general, not hundreds of patients with adoptive T cell therapy, but immune therapy in general. So this is something that can work. How broadly applicable it is remains to be determined. So we have CAR T cells, we have tumor-infiltrating lymphocytes, but can we do something else? Can we trap T cells without engineering T cells? And this is an emerging technology. Well, it's not that emerging, it's been around for a long time, but now it's being tried in solid tumors as well. And this is bispecific antibodies or BiTE technology. And the one BiTE that's been approved for leukemia is this blinatumomab, which is a T-cell engineering BiTE antibody. On the left side there, you can see an antibody against CD3, an antibody against CD19, and what they do here is take the variable regions from each of those antibodies and stick those together, and you have what is called a BiTE. And as you look on the right side of the screen, you can see that this BiTE, which has two sticky regions, one for CD3 and one for CD19, will stick to both the T-cell and the leukemia, and will make that T-cell think that it should attack whatever it's now stuck to, even though it didn't plan to recognize it in the first place, right? That T-cell could be looking for the flu virus, but it got stuck to a leukemia cell. But it's there, CD3 is engaged, so it's going to kill whatever it's closest to. So it kills that target cell. And as that target cell dies, it will release its neoepitopes, and there'll be an adaptive immune response. So this idea can work, and that's in leukemia. Whether this can work in solid tumors is a very different story. Again, just to recap the blinatumomab data, they had a large trial, 185 patients, 32% CR with 2 cycles of treatment, and this was durable, 6.7 months, so blinatumomab works. So what are these bispecific antibodies? On the left there, you can see the blinatumomab that we just spoke about, and then there's others. There's this bispecific antibody that recognizes CD3 and CEA in the middle there, has the 2 variable regions in green and blue that recognize CEA, and the orange and yellow one in the middle that recognizes CD3, and that one could target CD3 positive tumors. That's a Roche drug, and then the one from Pfizer is a DART, which is also similar to a blinatumomab. It's a smaller drug, but has the capability to recognize peak adherin as well as CD3, so that's an error. Peak adherin and CD3, so it does the same thing. There's targets on the tumor that it could stick to, and then it could trap T cells to go in. So this is one emerging technology. Then the next concept is what about MAP kinase pathway? So we've heard a lot about this from ASCO of last year, and can we manipulate the MAP kinase pathway to induce immune responses? And we know the answer is yes, but let's take a step back and look at what was achieved and what we can do going forward. So as a reminder, the MAP kinase pathway allows the T-cell receptor to tell the T-cell what to do. So there's going to be signaling from the T-cell receptor through RAS, RAF, MEK, and ERK. And this is important for T-cell receptor signaling. When it's a naive T-cell that's trying to learn what to do, initial signaling via this pathway will activate the T-cell, lead to IL-2 production, prime it, proliferate. It's an important pathway. But after a while, if that T-cell continues to have signaling through its T-cell receptor, it wants to turn itself off, right? Because it's most likely what it's seeing is a normal tissue that's around a long time as opposed to bacteria that's transient. So continued signaling via this pathway will cause PD-1 upregulation and T-cell exhaustion. So what we do with a MEK inhibitor is we turn off the bad part of the signal so that that T-cell that is now starting to turn itself off doesn't turn itself off and can go and kill what it was trying to kill in the first place. So MEK inhibition will allow rescue of these T-cells that are no longer naive, they're now memory, and prevent them from downregulating. By itself, this does not work. This is a graph of the initial phase 1 study of a MEK inhibitor, Cobimetinib, and on the right side of the graph there, all those blue lines are melanoma, they're all shrinking, but the green bars all going up, so all the colon cancer patients are progressing. So there's no response from a MEK inhibitor by itself, at least this MEK inhibitor in colorectal cancer. But if you combine that MEK inhibitor, so that MEK inhibitor upregulates the immune system, and you give it Atezolizumab to allow the immune response to be activated, it's effective. So this is the study design that Joanna Bendel has previously presented, a phase 1 dose escalation with expansion cohorts. These patients were KRAS mutant to start, and it was found that the MTD was permissible up to a Cobimetinib of 60 milligrams plus Atezolizumab every 2 weeks. And what Johanna has presented on the left side there is that this combination is effective towards shrinking tumors. So those green bars are microsatellite stable colon cancer that are getting smaller. At least 3 of them are confirmed microsatellite stable. 1 is unknown, but presumably it wasn't suspected MSI-high, but we really don't know. So we have 3 confirmed and possibly 4. So that would give us a response rate of 17%. And the real important point of this strategy is not only the responses, but the right side of that graph that shows that when there's a response, these responses can be durable. And you can see there, that's the timeline there is measured in months. So beyond a year, initial responses can be long-lasting. This is what we're getting used to seeing in immunogenic tumors, and now we're getting a glimpse that there may be the potential for this to occur in microsatellite stable colon cancer. But as a reminder, only 2 out of 4 patients got to the year mark. We're looking at 2 patients. We need more confirmatory data. So this trial is further expanded. We'll await on that data to inform us. But given the way that this appears on preliminary data, this was taken forward to a larger trial. What this slide here shows is a proof of principle that this is via an immune mechanism. So you can see from left to right, pre-treatment biopsies with CD8 in the top panel and MHC class 1 in the bottom panel. MHC class 1 will go up if there's an immune response via gamma interferon. And after Cobimetinib, there's an increase in T-cell infiltrate as well as MHC class 1. And if you give Cobi plus Atezolizumab, there's a profound immune infiltrate as a proof of principle. So the trial that this has gone forward with is this IMBLAZE 370 clinical trial, which has completed enrollment. This is done at multiple sites throughout the United States and Europe. It's a 3-arm randomized study in patients whose disease has progressed on 2 lines of chemotherapy. And they either get Atezolizumab plus Cobimetinib or Atezolizumab by itself or regorafenib. It's a 2-to-1-to-1 randomization. So this is enrolled. We're waiting on the data to inform us of the role of Cobi-Atezo in the treatment of metastatic colon cancer. The next trial is going to address that question of what bevacizumab can do to augment an immune response. And the rationale for combining bevacizumab with immune therapy is because it affects lymphocyte trafficking and immune regulation. So that concept was shown by some of the melanoma colleagues. So this is Steve Hode's data. This is from some of the biopsies. If you look on the right there, these are patients that were treated with CTLA-4 blockade, so melanoma patients with ipilimumab. So on the right, there's 2 panels there. There's pre and then there's on treatment. And the pre-treatment looks very blue, and the on treatment, you'll see those brown spots occurring. So the top panel is CD3, a marker of all T cells, and the CD8, the soldiers. There's not that many regulatory T cells, so we don't want to see a lot of FOXP3 going up. And then at the bottom, CD163, which are macrophages. So ipilimumab by itself will cause an immune response, but the important point is if you look at the 2 panels on the left, right, pre to on, there's a lot more brown cells. So if you add bevacizumab, that immune infiltrate that is being caused by ipilimumab is magnified. So there's a lot more CD3 cells, more CD8 cells, not that many more regulatory T cells, and a lot more macrophages. So this is a proof of the concept, well, some proof of the concept, that if you give bevacizumab, you can augment the immune response that ipilimumab is creating. And this has led to the clinical trial of Cobi plus Atezo, so we know that we're trying to explore the efficacy of that. Then the question is, can we make this better by adding bevacizumab? So this is a 3-drug combination trial, which is currently enrolling. The Atezo is every 2 weeks, Bev is every 2 weeks, and Cobi is given daily for 3 out of every 4 weeks. So far, we've completed the 12-patient safety run-in, we as in the global trial, and once that's complete in about 6 weeks or so, it'll open to a biopsy cohort as well as a further expansion cohort to further validate this. So this is a good trial for patients to be on. The last concept for colon cancer is radiation. We don't know where radiation is going to fit. We like to talk about abscopal effects. They're anecdotal. We talk a lot about them, but can we learn something from them? We probably can. We're not sure where it's going to fit yet, but it does happen, and this is Mike Postow's initial observation in a patient with melanoma who was getting ipilimumab and progressing, and at the time of that red line in the middle, after 2 scans, got radiation to a symptomatic pleural-based MET, and as you move further right, you can see that pleural-based MET and METs in the mediastinum and the liver and spleen, well, spleen, not liver, got bigger, but eventually regressed. And this was not a delayed response to the IPI, this was real progression, which then became systemic immune activation with an abscopal reduction. So we took this and asked the question of, can we do this in colorectal cancer? So patients were given pembrolizumab, and either they got radiation or they got ablation, so cryoablation or radiofrequency ablation to release those antigens. Patients had to be eligible for one of those standard procedures, and then they got pembrolizumab within 1 week of either modality to look for an abscopal effect. Out of the 22 patients that received radiation, the majority had radiation to a lymph node or a liver metastasis. 3 had a lung lesion, 2 had an extra-ovary, 3 bone, 1 peritoneum, 1 and 2 in the soft tissue. So the results of this trial are really underwhelming, but we could learn from the 1 or 2 responders. So there was 1 PR and 2 patients that had a mixed response. So it's a negative trial. The majority of patients had no benefit, but the patient that did have a benefit had a profound benefit. So here you can see a baseline scan and an on-treatment scan done about 5 months later with almost complete disappearance of an internal mammary lymph node and regression of lots of pleural disease and a pleural effusion. And this response is ongoing still. The patient has had 2 escape lesions that have been resected up until this point, but they're on study now for almost going on 2 years. The patients with the mixed responses, there you can see from left to right, the 1 patient on the top, the other patient at the bottom, and tumors were getting bigger. The RECIST responses were mostly flat, but there was clear regression in scattered lesions. And there those arrows point toward a lung lesion on the top that got smaller, another lung lesion in the other patient that also got smaller, where other lesions got bigger. So there's a mixed response there. So how are we going to develop this? There are at least 3 clinical trials that are now asking the question of what can radiation do in combination with checkpoint inhibitors. These are combination trials of PD-1 plus CTLA-4 blockade. The trial that we're opening in about 2 weeks is a phase 2 study to assess the efficacy of durvalumab, the anti-PD-L1, plus tremelimumab, the anti-CTLA-4. Each of these modalities alone effective in preclinical models, plus radiation ablation in metastatic colon cancer. So these patients have to be eligible for standard therapy. They receive durva plus tremi. They can have prior immuno-oncology, so PD-1's allowed. They get 3 biopsies, and this is a trial. If you have patients that we would like to put on these, please, let's discuss. The next feature, so this isn't a slide that I'm going to go through, just to make the point that there's lots of options when we talk about checkpoint inhibitors. So many of these are going to be combined in various different ways. We'll release the brakes, we'll give an agonist to upregulate the immune system. There are many clinical trials. Multiple of these trials have colorectal cohorts, and we'll learn a lot about how we can combine checkpoint inhibitors. So for the last slide, if I digress away from colon cancer, I'm going to just give you a brief summary of some of the more recent changes. This is by far not an inclusive slide, because the results of each individual disease type will be discussed by those disease specialists. But we have learned of the efficacy of PD-1 blockade in hepatocellular carcinoma, with responses around the 20% in patients that have had prior sorafenib and patients that have not had it. So there's efficacy of PD-1 blockade in liver cancer, independent of viral status, Hep C, Hep B, or uninfected. So there's ample room to move forward with checkpoint blockade in liver cancer. Within gastric cancer, multiple successes. The initial KEYNOTE-012 study with pembrolizumab, a 22% response rate. And then, of course, the phase 3 clinical trial in Asia that was positive for nivolumab versus a placebo, with an 11.2% response versus 0, but with a survival benefit of 5.3 versus 4.1 months. And that's obviously very encouraging. And then there's the other data that presented by Yang Li and then Yelena Janjigian, showing improved efficacy of combining PD-1 blockade plus CTLA-4, and this will move that forward toward further studies in gastric cancer. And then Kathy Yang's study in anal squamous cell cancer, which was just published in Lancet Oncology. Congratulations, Kathy. And that a terrific proof of principle, a phase 2 clinical trial showing efficacy in anal squamous cell cancer with a response rate of 24%, or a PFS 4.1, and an overall survival 11.4 months, again showing us that there's efficacy of checkpoint inhibitors in that disease. So in conclusion, GI cancers may be targeted by an augmented immune response with clinical benefit in a subset of patients, including colorectal cancer, MSI-high, we're going to see how that's going to work in microsatellite stable, but also gastric, HSC, pancreas, which I didn't mention, anal cancer. Within colon cancer, there are 2 immune subtypes, maybe 2 different diseases, but for now they're both colon cancer, 2 different immune subtypes. MSI-high or highly immune responsive microcell stable for reasons of biology, or immune void or precluded despite having enough mutations. And then going forward for immunotherapy to become effective in the treatment of conventional colon cancer, we must convert tumors to inflamed, and then we can give them PD-1 or anti-PD-L1, and we'll do this with dual checkpoint strategies, and we'll learn which ones to use. We'll explore combinations with radiation, we'll modulate the MAP kinase pathway, and then we'll employ strategies to mobilize T cells into the tumor. Thank you.